Good afternoon, everyone. My name's Dr. Ajai Seth. I'm a consultant in sports medicine, primarily based at the HCA site in London Bridge. I also work for British Tennis over at the Lawn Tennis Association and do some lecturing at King's College London. And we're going to be talking about apophyseal injuries. So we'll briefly cover what apophyseal injuries are, what the most common ones you might see in your sort of clinical practice, and a bit more about the risk of who develops them and what we can do to treat apophyseal injuries. Prevention is always key, so we'll talk about the main risk factors and what we can do about them, trying to make sure we protect our younger population from getting apophyseal injuries in the first place, and then I'll send you home with some key take-home. What is an apophysis? Essentially, like any physis, an apophysis is a normal secondary ossification centre. The difference with an apophysis is normally associated at a non-weight-bearing part of the bone, and it normally has an important tendon or ligamentous attachment to it, as opposed to a joint apophysis, or a joint physis in between bone here. Most of the apophyses fuse actually in the second decade of life, but the process can be delayed for various medical and other reasons, which we will discuss. How do they get injured? They can be injured by acute trauma, which you can get avulsion of the apophysis, or by chronic overuse, and that's by far the larger proportion of the injuries we tend to see, particularly in the sporting world. And you've got to remember that with any physes, you can get other pathology there. So it's important to make sure that you're not missing any other lesions in and around the growth plate. So we'll just start with the closure of growth plates. And the first thing to take home from this slide is that it's very variable. So you can't really assume that a growth plate has closed without getting appropriate imaging and investigation. As a general rule of thumb, you may get the more proximal growth plates, particularly around the hip and groin area and the shoulder blade, closing a bit later on. But just to get a general sense of the age of the patient you're seeing and the type of injury they're presenting with, I think apophyseal injury should always be at the forefront of your mind, not assuming, oh, the growth plate's closed, unless you've had the appropriate investigation to dispute that or prove that. So the common ones you've probably heard of, we all know about, to look out for are things like Osgood-Schlatters, which is obviously an injury at the tibial tuberosity. Syndig-Larsen, which is slightly underdiagnosed, I would say, but that's more to do with the inferior patellar junction. And Sever's disease, where we're talking about the posterior calcaneus, where the Achilles tendon is pulling on the posterior calcaneum and causing a traction apophysitis more commonly. The ones you may not have heard so much about, and when you are assessing patients to keep sort of an open mind, are to do with the elbow and the shoulder, particularly around the hip and groin, which often presents as a bit of a minefield for apophyseal injuries, and we'll go into that in certainly more detail. But even the foot as well. So metatarsal, particularly around the base of the fifth of metatarsal, where the peroneal brevis tendon attaches, can often cause a site of pain. So it's often really important to make sure you're considering these when you examine these areas in young and adolescent patients. So this study was taken from the British Journal of General Practice, and if you look at the top graph, actually the main points to note are the top line here is looking at the incidence of Osgood-Schlatters in boys. So firstly, boys out-trump girls by quite a long way. The second thing to notice is that actually the onset of Osgood-Schlatters is much earlier in girls than boys. And there are lots of reasons why that is the case, primarily hormonal and when adolescents go through their growth spurts. And we'll talk about how we can mitigate that in a few moments. This study is looking more to do with fitter and more active adolescents. So it was looking at English Academy football across the country and comparing Severs and Osgood-Schlatters. And again, you can see the primary age groups at risk here are anywhere from the under 14s to the under 12s. And actually Severs is a more common in the fitter and active, particularly lower limb sporting population. So it's an important diagnosis not to miss. How do we diagnose apophyseal injuries? I think most imaging modalities have actually a key role here. most clinicians or sports doctors now use ultrasound in clinic. So what we can do is clinically assess and do an ultrasound scan at the same time. And what you can see here is cortical fragmentation of the apophysis. So essentially lots of bits of bone becoming pulled away from the bony insertion. You can also see lots of inflammation and edema, but you can also see some telltale signs of a bit of bursitis. And this is the patella tendon inserting onto the tibial tubercle, and that is classic Osgood-Schlatter's appearance. And of course, you'll be able to compare it to the other side when you're doing your scanning and assessment. This is an MRI scan of a heel, and you can see here that you've got the physes and apophysis in the calcaneum. And interestingly, you can see how the Achilles tendon actually looks completely normal. So in this particular patient, I think they had gone down the route of it being an Achilles tendon injury, where actually the Achilles tendon looks plumb normal, but what's happening is the Achilles tendon is pulling on the physes here and causing lots of bone marrow edema, lots of swelling, lots of pain. So this is when things get a bit more complicated, and lots of hot spots around the hip and groin and pelvis area. So I guess one take home from this message is if you see someone, a child, adolescent who's got a hip and groin area, don't just assume that it's not to do with the hip joint, because there's other things going around that sort of area, particularly with muscle attachments. And often you need a real detailed clinical assessment, history taking, and appropriate imaging to try and match up the diagnosis. And often it's a bit of a spot the difference between the two sides. And apologies if it doesn't project all the way to the back, but what we can see here is you've got a bit of a traction apophyseal injury all the way at the iliac crest. And I would be thinking about this type of injury in someone who has a lot more abdominal or core activation. So for example, someone who's doing gymnastics or other sports that require a lot of abdominal strength and core strength. On the other hand, you look a bit further distally. This is a very common one we see in the UK, given our love of the game, football, where you've got a rectus femoris injury here. So the rectus femoris muscle has pulled on the anterior inferior iliac spine and causing an avulsion injury here. So this is a very important one not to miss, actually. In terms of management of these, I think it's managing the reason they've happened in the first place is where we'll start. Sometimes they do need a bit of surgical intervention, or at least liaising with our surgical colleagues, particularly if the traction injury has pulled the bone fragment quite a distance away from the apophyses, particularly at this area here around the hamstring. So let's talk about the risk factors for apophyseal injuries. Growth spurts. So we all know children grow, but what we're not very good at is actually plotting when they grow. So actually, during the time of a growth spurt, we know that the physes become much more active and much more hyper-responsive, but actually that makes them more prone to injury. They typically start later in boys due to rise in testosterone being a bit later than estrogen and progesterone in girls. And boys generally get most of their strength characteristics after or when they're going through the growth phase. The thing they always lack on, though, is flexibility. So they always lag behind on flexibility, which acts as a risk factor for getting apophyseal injuries, as we'll see. So in terms of what we can do to try and prevent that, I think it's really important to be determining what we call peak height velocity and planning for it. So what we mean by that is simply finding out when they are going to be achieving their growth spurt. Very easy way to do that is, I don't know if you remember your mum measuring you up on the kitchen wall, but if you plot that every 3 months, you can obviously plot the rate of growth. Even easier than that, there's lots of very clever people on the other side of the pond that have developed online calculators. So actually all you need to do is get these measurements, put them into the online calculator, and then it will determine when the predicted peak height velocity is. What do you do with that information? You can plan around the level of training you're doing, the type of exercise you're doing, and just basic exercise and load management. So very, very important, very easy to do. So we should be making the most of that. When it comes to training, obviously we want to avoid high excessive impact and high velocity training during the growth spurt, and that's really key. So if someone had a huge competition planned for when their peak height velocity was just about to come, and you might want to build their training program around that and try to mitigate those circumstances. And we do that particularly a lot in elite sport and adolescent sport, where we've got the environment to do that. Incorporating rest days is very important as well. There's a concept called biobanding, which we use a lot in elite sport, where actually what you're doing is grouping athletes together on growth and maturation rather than age. Because we're all different, every child will grow differently. So it's actually making sure that they are competing at the same bio-banded maturity status rather than age. And rest days and variation of training. The last thing to look at is strength and conditioning. So how many children or adolescents who play sport at a young level actually have a good strength and conditioning program? And we know that lack of muscular strength and particularly flexibility, as we mentioned in boys, is a real key risk factor in terms of producing apophyseal injuries. So introducing these concepts, asking young children to get involved with more physical activity that's more strength-based rather than just running around a football pitch for hours on end is really, really key. Why is that important? If we just take you back to a bit of muscle physiology, we know that when the sarcomere, so the muscle fibre, is at maximal stretch, actually we get more stress and tensile strength through the muscle. So the longer and stronger the muscle, the better. So it's really important to get that concept across. Lastly, I just want to focus on what I see my job as a sports physician is really. It's educating patients, because there's not one golden bullet cure for any apophyseal injury. So you have to really work through all these factors and understand where are the opportunities to optimize here. In children in particular, a lot of children obviously are concerned about image and appearance. You have to ask about dietary intake, calorie intake, and seek appropriate health. Hormonal delays, whether that's precocious puberty, whether that's delayed puberty, there may be hormonal reasons for that. Mental health, very, very important. I mean, how much pressure is on kids? There is an epidemic of injury when mothers and fathers are trying to get their kids into grammar school on a school scholarship. So, sport level goes through the roof. Social media, big factor. How are we making sure we're protecting our young people so they're not overtraining, over-exercising, wanting to get into ballet school, wanting to get into make weight, all that kind of stuff. And our job is to really go through all those factors for our patients, and at the end of the day, make them understand how they can balance their training and empower them. So the key take-homes are, obviously, educating our patients around training load and volume is key. Calculating the age of predicted height velocity, I think that's a very, very easy thing to do, and the more we educate our younger population, adolescent population about that, the better. Length and strength of muscle, very important, get those concepts in early. Try not to use the term growing pains. I think it's very unhelpful, and I think actually it gives a false sense of security to actually where things could be optimized much better. I know it's a very easy term to use, but actually I think we can be better in terms of our diagnostic certainty than growing pains. Yeah, and common things are common, but don't assume. Make sure you get the appropriate investigation and refer if you're not sure. Thank you very much.